To conclude the session's focus on reproductive health and sexuality, we have Dr. WINIKOFF speaking on the topic of hormone therapy. Dr. Rochelle WINIKOFF is Assistant Clinical Professor in the Department of Pediatrics at the University of Montreal. Since 2003, she's a staff hematologist at Sainte-Justine, where she's the current clinical director of the Women and Bleeding Disorders Interdisciplinary Program. She's past and current interim chair of the AHCDC Women and Bleeding Disorders Committee. She's also the current co-chair of the Hemostasis Committee of the CPTHN. She's honorary chair of the CHS National Code Rouge Program and recipient of the 2019 CHS Cecil Harris Award for her contributions to advancing the care of women with inherited bleeding disorders. Please welcome Dr. WINIKOFF.
Thank you very much. I know this is keeping us before lunch. I think lunch is next. Yeah. So thank you for the organizers for having me present today. And I'll be approaching hormonal therapy, is it for me, from a hematologist perspective. And secondly, I have no disclosures related to the content of this talk in particular, but I do have a confession, so I am not a gynecologist. So please don't rely on me for the nitty-gritty details about different contraceptive choices in terms of hormone pills. What I will be addressing today is more so the overall considerations that we need to have in mind when we're treating women and girls with heavy menstrual periods and making those choices with them. So, I'll be just going through a little bit about defining heavy menstrual bleeding. I'm going to talk a bit about the consequences. I'll talk briefly about the hormonal options, and I'll point out some of the shortcomings of hormonal therapy. And I'll be addressing some of the cultural and social barriers to hormonal treatments. And then lastly, I'll be mentioning the role that we can have as a community to try to help overcome some of the barriers in having these discussions about hormone treatment. So this is not the right slide deck. I don't know, there was a version that, there's a later version than this. Is there a way to call it up? Sorry for this, but I'll continue in the meantime with what I have here. So, I'm just going to go through some definitions you probably all know, but it's important when we're talking to each other that we understand what the definitions are. So the first is abnormal uterine bleeding. So this is a normal menstrual cycle that lasts less than 7 days, that has interval of 21 to 45 days, and what's considered normal is going through passing 3 to 6 pads or tampons per day. So the opposite of that is abnormal menstrual cycle, which is prolonged more than 7 days or excessive, which is defined as more than 80 milliliters of blood loss per menstrual bleed, and with uterine bleeding occurring at regular intervals. So the tricky part is really the 80 milliliters, and we've heard this in some of the other talks that we heard yesterday in the CPTHN, and we hear about it a lot. So we're not very good at quantifying 80 milliliters. It's not a very convenient definition, but we try to do it qualitatively by asking the right questions. Are you changing your pads every hour? Are you passing clots? Are you soaking through night clothes? And if you have iron deficiency anemia, this could be a criteria as well. We also try to quantify and semi-quantify menstrual bleeding. So on top, on the left, what you have is an image of a woman or a girl with heavy menstrual periods and her pad collection during a heavy period, compared to a woman that does not have heavy menstrual bleeding and how many pads and tampons she goes through. So it's a very visual representation of what we're talking about when we try to objectify heavy menstrual bleeding. And just by a show of hands, does everyone here know about the menstrual cup or the Diva cup? Yeah, so most of you. So if I would have asked that question going back 5 years ago, I assume that a lot of people wouldn't have known about it. It's become much more popular, especially in Quebec, than it used to be. And that's a graduated cup that lets you quantify. And then we have semi-objective tools that many of you know about. And the picture on the left bottom is the pictorial blood assessment chart. And basically, it's like a bowling sheet. Every time you switch a tampon or a pad, you indicate how soiled it was, and you establish a score. That's also available on an electronic app. So we tried to quantify. But I think what's much more important is that the FIGO, so the International Gynecology and Obstetrics Group, have found a definition that I think is much more realistic to everyday life and is much more applicable to patients, which is now defined as excessive menstrual blood loss which interferes in the woman's physical, emotional, social, or material quality of life. So we can see the applicability of that it's user-friendly, but it also speaks to the patients and what they're living. This is a slide that most of you have seen in every single talk I've given, and it's published by some of our Canadian colleagues back in 2006, but I think it's very telling in terms of quality of life. And we're going to go into some more details about quality of life around a case. But here, what the arrow is showing is a female adult with von Willebrand disease who has a quality of life that's scored at 0.7, 1 being a perfect quality of life. What you see is the male with von Willebrand disease has a slightly superior quality of life, but still inferior to perfect. And then what you see are females with bleeding disorders with heavy menstrual periods that have a decreased quality of life of 0.64. And what's most striking about this slide to me is that is almost the same quality of life that hemophiliacs that are HIV positive attribute to their quality of life. So what we're saying here is the severity of the quality of life that's affected, or the life that's affected with women that have bleeding disorders and heavy periods is really close to very seriously diminished. Are we able to, did we find a new slide deck or? Sorry, it's the right one now? Yeah, okay. So the frequency of heavy menstrual bleeding in women in the community, 30% of women will talk about it, say that they have it. If you use more semi-objective scores, you might say that 10 to 14% of the general population complain of heavy bleeding. But if you look at the cohort of patients that have bleeding disorders, you're talking about 59 to 93% that will complain of heavy menstrual bleeding. And one of the most important comments that I'm going to make on this slide and the segue to the rest of the talk is that self-reports are influenced by a lot of things. Primarily who you're talking to. If you're talking to your mom who has heavy bleeding, she might think that that's normal. But particularly, the self-reports require that a patient comes to medical attention and speaks about it. And we just heard a talk that says that we have to initiate conversations because not all patients are coming to report to you. And it's subject to cultural influences that can be very important and that we need to be very sensitive to. So on the left here, I've defined what we call taboo. So patients sometimes don't talk about it at all because it's a taboo subject, which means that it's a social or a religious custom prohibiting discussion of a particular practice or prohibiting association with a particular person, place, or thing. And then there's also a stigma involved. And a lot of the stigma can be societal, but it can also be personal. And what I've marked here, what I've defined stigmas here is a mark of disgrace associated with a particular circumstance, quality, or person. And what you have in the image to the right bottom, does anybody know what this is? Period hut. Does someone sit at the back? Bravo. So this is a menstrual hut. This actually exists in several societies, in Nepal, in India, I see people nodding their heads, in Ethiopia, and where women and girls who are having their period need to escape or need to be put away from the main village or the city in a type of quarantine where they are not allowed to cook and people bring food and they stay there. Now the problem is that they're largely unsafe, they're not well protected, they're not well insulated from wildlife and from the elements. And so I know, at least in Nepal, that this has been outlawed since 2019. I don't know about some of the other countries. So the personal stigma, this is, and I appreciate that they lent me this slide, it was given to me by the World Federation of Hemophilia during a women's session. And this is a survey of women from the Middle East. And it speaks to the stigma that's associated with heavy menstrual blood loss. And I can barely see that, but it says that during my period, I can't even see that. Can't see it over here. But basically, I'm not allowed to touch babies during my period. And on the right here, what it's going to say is I describe my menstrual period, 7% described as a sickness, as embarrassment, or as that I hide it from men. So these are common things that women will say about periods. So we have to understand as clinicians, this comes from a very deep place, and this is not something we can expect in a 10-minute clinic visit that we're going to break down all these barriers in a single session to discuss. What we also know in general, and this slide is a bit busy, but what it speaks to is the fact that when we do address this issue, we're successful at doing it. So if you look at the top graph, what it's showing you is that the PBAC scores, that's the semi-objective measure of heavy menstrual blood loss we saw in an earlier slide. When we look at a cohort of adolescents, for example, that are on a hodgepodge of different treatments, hormonal and non-hormonal, we actually managed to decrease their PBAC scores. And another important aspect here is that not only do we decrease the scores of how much blood they're losing, but we also improve their hemoglobins and we increase their ferritin levels, which we know that iron deficiency has a huge impact on quality of life. We also know that patients are satisfied when we do this. This is a study from 2023, where in 68% of cases, the clinic, usually an interdisciplinary clinic, but not necessarily, were able to control the heavy menstrual bleeding when we applied ourselves. It often takes more than one try, sometimes combined therapy, but we end up having successful treatment. So I'm going to throughout this, I'm going to bring up 3 cases, and I think that many of you could identify with this. This is a 13-year-old girl with type 1 von Willebrand disease. She had her menarche at 12 years old with very irregular cycles and heavy menstrual flow. She's now anemic, she's fatigued, she's missing school, and she's withdrawn from all sports activities. Her parents are very concerned. They're also concerned that she's getting depressed, and there seems to be a strong family history of depression on the maternal side. She visits her family doctor to find a solution for her heavy flow, and her doctor reviews the treatment options with her. So after she considers all the treatment options, she opts to try the combined oral contraceptive pill. Within 3 months of starting the pill, her cycles normalize. So they were irregular, now they're normalized, and her menstrual flow decreases, but now she feels bloated, she's gained a bit of weight, and she's feeling depressed. Her mom is increasingly concerned and returns to the family doctor for advice. After some discussion with the patient and her mom, it's decided to stop the pill, which is assumed here to be contributing to her worsening symptoms. After discussion with her hematologist, to whom she was referred, she started on tranexamic acid in place of the pill, with good response, decrease in blood flow of approximately 50%, and her cycles returned to being irregular, unfortunately. IV iron is also prescribed to help her with her fatigue. So some of the points that I want to bring up here are, first, that we should know as an audience and as healthcare givers that the contraceptive pill, the combined oral contraceptive pill, is actually one of the 2 therapies that's recommended across internationally as first-line treatment in women and girls with bleeding disorders. And it also helps with anovulatory bleeding, which can be specifically problematic in the early years of after menarche. But we also know that hormonal treatments can have both physical and psychological side effects that physicians, we need to be aware of, and we need to coach about this before. And in this particular case, in this particular patient, it worked out that the hormonal treatment that we recommend as first line was not working for her. And so we went back to tranexamic acid, and certainly this is another option if the contraceptive pill is not working. So this is a publication on the international consensus on the treatment of at the time the term was menorrhagia rather than heavy menstrual bleeding, published in 2009. But I find it extremely pertinent, and I think as clinicians we should all have this in mind when we offer patients treatment. And basically it starts off with the question, would the patient like to preserve fertility in the long run? If the answer is no, we're looking at hormonal treatment or surgical treatment. If the patient's answer is yes, the next question we ask is, would the patient like to become pregnant now, yes or no? And if no, we revert to hormonal therapy. And if yes, we're going to hemostatic agents that are specific for their underlying bleeding disorder. So DDAVP, tranexamic acid, or anything that's not hormonal. Now, we already mentioned that the hormonal treatment should be considered for first line, and I get a lot of questions about patches, pills, rings. They're all combined oral contraceptives, and they're all equally effective as contraceptive agents. There's not a lot of studies looking at it in terms of the control of the heavy menstrual bleeding, so I can't answer that as a non-gynecologist, but I will say that some of the other combined hormonal treatments are very good options. The pill helps with cycle regulation, as we saw in our patient originally, that her cycles return to being much more balanced and less flow. And it helps with menstrual cramps, and it helps with PMS. Also, adolescents have a preference for the continuous more than 3-month therapy, because then they don't get periods and they have very few breakthrough bleeds, and this helps improve their social life and school attendance. The other thing that people need to retain here is you don't need to know all the ins and outs of all the pills. This is the advantage with consulting either a pediatric gynecologist or an adult gynecologist. But it's clear in the literature that there's no combined oral contraceptive pill that is better than another in terms of its effect on contraception or even in controlling heavy bleeding. So now the question is there a psychological effect of giving hormonal treatment? And so in our patient, she was a bit depressed and she was a bit down and she was a bit anxious. And then it brought us to discuss, is there any contraindication to, from a psychological point of view, for hormonal treatment? And the real answer is no. And the CDC and the WHO guidelines are clear on this, that even in the face of a severe psychiatric diagnosis, so major depression, bipolar, there's no actual contraindication to offering your patient the contraceptive pill for first-line therapy. However, in some women, there will be mood changes, and slight depression can get a little bit worse, certainly at the beginning in the first few months. And it's really important to be aware of that. Like in our patient, we had to stop because it was deemed that she couldn't support continuing. It might be related to the hormone in the pill, the dose, etc. And perhaps another contraceptive pill would have been a good choice for her, but she was very discouraged and the parents too worried to be able to continue. So we switched her to non-hormonal therapy. The other issue is weight gain. So on the left, you see 2 studies that were done, quite rigorous, in fact, looking at the fact whether patients gain weight or not when they're on the pill. And the brief answer to that is no. There is no evidence in the long term that the pill causes weight gain. And this was even looked at in an obese population. However, there is some fluid retention that's related to the estrogen content, and there is an increase in appetite at the beginning, mostly related to the progesterone content, and those things usually subside after several months. But we need to tell patients that if we're expecting compliance. So I'm going to switch now to case 2. This is a 15-year-old girl with Glanzmann's thrombocythemia. Her menarche was marked by a very heavy period, flooding, blood clots, a real horror. She spoke to her mother about this confidentially, and they consulted the family doctor. She was initially started on tranexamic acid 3 times daily with some notable improvement in the flow. But despite this improvement, she became anemic, she required oral iron, and then eventually transitioned to IV iron. The persistent anemia led to school absenteeism and to decreased social activities. They subsequently reconsulted the family doctor to have access to a hematologist to discuss further alternatives for the heavy menstrual blood flow. Now, after going through the algorithm with them, the only ones that they were interested were anything that was non-hormonal. They didn't want to have anything to do with the hormonal treatments. She was tried on intranasal desmopressin, and it had some mild effect, but it didn't work all that well. The effect was not any better than tranexamic alone, so we abandoned that. And then the patient experienced repeated bouts of iron deficiency. She was really losing out on life. She stopped going to school. She stopped having friends. She was sleeping all the time. I can say that her quality of life was probably one of the worst that we've ever experienced in the clinic. And the family found this increasingly difficult. At the subsequent clinical follow-up, we opened the door to rediscuss hormonal therapy, which are still considered first-line therapies. And these were suggested along with a consultation in pediatric gynecology. It was tense in the room. The patient and her mother started looking at each other in silence. It made me uncomfortable. I was the physician here. And the mom shook her head like this, no. So I was almost embarrassed or uncomfortable moving forward with this discussion, but then I opened the door and I asked if there was a fear of this being linked to sexual behavior. And the mom nodded with her head down and the patient stayed silent. So some of the points I want to bring up here is that if you don't offer the right therapy and you don't offer therapy at all, you can have very severe impacts on quality of life, especially in this girl. It was really horrific. I think that a lot of the times, and we'll get to this in the concluding slide, that the term contraceptive pill is one way to close the door to conversations, and I'm going to get to that in my suggestions for moving forward with this. There's definitely a taboo around the pill, and it's concerned about the relation to sexuality, even promiscuity. And also there's some concern that the other option that's hormonal as well is the IUD, that's hormonally impregnated with progesterone, is not offered to young nulliparous women or young adolescents. So when we look at this particular patient, and this is a slide again repeating that heavy menstrual bleeding has a horrible effect on quality of life in women and adolescents. But also, if you look at the bleeding disorders community in particular, heavy menstrual bleeding has a large impact on health-related quality of life that probably surpasses those of women that have heavy menstrual bleeding without underlying bleeding disorders. School performance, 12% of adolescents have adverse effects on their performance, 50% miss school. In the adult data, in older patients, 30% miss work. 50% are limited in sports activities and 45% in their social activities. And to the right, and as a nice segue to, as a follow-up to the previous speaker, this is something we don't talk about very much, but it's in a recent publication looking at the adverse effect of heavy menstrual bleeding on sexual activity in young women. And what you see here to the right bar graphs, you see a bar graph that represents sexual activity in, reported adverse effects on sexual activity in premenopausal women, and then non-menstruating women to the right of that, at the far right. So what that's showing you is that the premenopausal women that have heavy menstrual bleeding in our community are reporting difficulty with sexual activity. Part of it is post-coital bleeding, but some of it can be literally in more severe disorders, hemarthroses, muscular bleeding in some forms of sexual activity. I point out this slide that was done in the United Kingdom, where I should preface by saying that they have a very multicultural community. And it's a bit older, these studies, but I just want to show you what is prescribed in general, and this study comes from the UK. So if you look at the blue arrow on top, adults with heavy menstrual bleeding primarily are started on the pill right up front, and that's the primary treatment. If you look at the chart below, looking at adolescents, you can see that the combined oral contraceptive pill lags behind tranexamic acid. And this speaks to some of the concerns we just brought up. And in both of these charts, both of these tables, the intrauterine progesterone device is much lower. But again, at the time, this was before some of the recommendations came out and looking how efficient it was to treat heavy menstrual bleeding compared to the pill. So I suspect if this study was redone now that the uterine device would be much higher. And then there's a fear about, like I mentioned, can young women get an IUD? So people have fears of the old ones that were copper, that caused more infection, more bleeding. These are impregnated with progesterone, and they thin the uterine lining. And actually, if you look at the data, they have an efficiency that surpasses the combined hormone contraceptive pill. And in most of the guidelines, this is recommended as first-line therapy for young girls with bleeding disorders that even surpasses the recommendation for combined oral contraceptive pills. It has a 90% overall efficacy. It has a 56% amenorrheic rate, so periods stop completely. And the American Society of Oncology and of Obstetrics and Gynecology supports its use and endorses its safety in women, including adolescents. And what I've shown you in the picture here is that the marketing name for this is known Mirena. I'm sure most of you have heard the term Mirena. I don't know how many of you have heard of Kyleena. Raise your hand if you've heard of, so not as many. And Mirena? Everybody. So Kyleena is a smaller version that was developed by pharma to facilitate insertion into young adolescents. So just to show you the incentive was there because we know how efficient it is. We also know that the pBAC score, again, looking at the flow, decreases significantly before and after the insertion of, in this particular slide, is talking about Mirena. So the parental role that a parent could have in adolescent usage of the pill or any hormone therapy is not to be neglected. Again, in that room that I was talking about before, it's the mother that was probably a little bit more closing the door than the daughter, who was looking at me with these eyes like, help me. And I think the mother had some nonverbal influence on the daughter's ability to respond or even engage in the conversation. And this is an excerpt from a 2023 article, and it actually was done in Uganda. And what it shows is, I don't support it for my children. So that's the title of one of the comments in this article. And these were in-depth interviews with 15 parents, and it was clear and flagrant that there was a lack of parental support. And here are some of the quotes that come up in the article. Telling an adolescent, for example, to begin swallowing things like pills is an indirect way of telling them to go ahead and have sex. It encourages immorality would be good. It encourages immorality in adolescence. And for the theme of promiscuity, this I hear a lot. I can only refer you to several studies, but the first one was published in 1971. And it says that the widely held belief that the advent of oral contraceptive will lead to promiscuity among the unmarried is examined. Evidence is presented. And an analysis of the causes of this change suggests that oral contraceptive is not a major causal factor in promiscuity. So I think it's one of the things that we can tell our patients and their parents when we're having this conversation. It's going to be a very short last case and then some concluding remarks as a community where I think we can intervene and where we can help. This is a 50-year-old woman now with moderate factor VII deficiency. She presents to her gynecologist up front, complaining of irregular heavy periods for the last 6 months. As a teenager, she was treated with the combined oral contraceptive pill with very good control, and she's seeking that again. She wants to restart the pill since she finds that heavy menstrual bleeding is intolerable and it's really adversely affecting her marriage and family life. And here when I'm saying adversely affecting her married life, like divorce papers on the horizon. She's overweight, she has poorly controlled diabetes and is being treated for hypertension. She gave up smoking last year. So the points are, there are some contraindications to hormonal therapy, and some of them are very important, as you all are very familiar with. But you really need a proper risk evaluation assessment and counseling. I put them up here. This is not an exhaustive list, but it's a very complete list, and you can see some of them here. One of the ones that applies to this patient is 2 or more risk factors for cardiovascular disease, such as older age, obesity, diabetes. And smoking. So for somebody with a thrombophilia, with a previous clot, people with migraines, people with breast cancer, these patients would not be eligible for these hormonal therapies that we just spent the last, 25 minutes discussing as number 1 therapy. So this will be the last slide, and I'm looking at all of you saying, what can we do about this? So I think the first role that we have is to be familiar with the choices that we have, both hormonal and non-hormonal, recognizing that the hormonal options are the most efficient way of treating heavy menstrual bleeding in our patient population. Obviously be attentive to contraindications, comorbidities, and monitor the physical and mental health effects that may be temporary but can worsen before they get better. And I think we cannot break down cultural differences completely. I think we need to be sensitive to them, and we need to understand that these may represent not only barriers in reporting heavy menstrual bleeding, which gets us to the doctor's office, but also barriers to providing optimal treatment. I think we need to normalize hormonal treatment, akin to any other treatments that we would give for heavy menstrual bleeding. One of the ways to normalize is, I think, as a community, when we're treating heavy menstrual bleeding, I think we need to drop the word contraception. I think it would help, unless it's specifically prescribed for contraceptive purposes. But when it's prescribed for heavy menstrual bleeding, I think we need to talk about it as hormonal therapy, and this helps normalize both for the patient and their parents. I think, like we heard in the previous talk, that the change that we're after here needs to focus, the discussion needs to focus on improving quality of life for the patient. And that's the goal. And then giving all the possible options and normalizing, like I said, talking about hormonal treatment. I think we have a role to minimize some of the fears and demystify some of these treatments that we just heard about, contraindications, promiscuity, that the IUD is not okay for young people. And I think that I will always advocate for a multidisciplinary care. I feel that, again, I'm not a gynecologist, and we count a lot on our colleagues, counselors, social workers, psychologists in some cases, gynecology, internal medicine, hematology. And by working in a group, I think we can achieve something better than what we see now, with knowing so many people are not well controlled and so many people are suffering with low quality of life. And part of that is because we can't get around some of the cultural limitations and personal taboos and myths around heavy periods and treatment. That'll be it. What time for questions?
Looking at the time, I think we might have a question for maybe just time for one question, if anybody has a question that they'd like to ask.
Thank you for an excellent talk. I'm Oksana Prokopchak-Gauk. I'm a hematologist from Saskatoon. I was wondering if you have any comment on Nexplanon devices, these subcutaneously sort of applied devices, and whether or not we should be discouraging them in our bleeding disorders patients or not, just because of hematoma risk and things like this.
So we should not be discouraging it. I didn't mention it here because I was talking about combined hormonal therapy in large part. This is a progesterone-only implant, and we should not be discouraging it. If we're very worried and the patient has a severe bleeding disorder, perhaps think about giving a dose of tranexamic acid before it's implanted so that there's no hematoma. But then after that, there should be no problem. It shouldn't be any different than in any other patient.
Thank you so very much, Dr. WINIKOFF.